We are live now, doctor.
A warm welcome to everybody here who are listening to this. We from YOSI, the Young Ophthalmic Society of India Journal Club team. So we are bringing to you another captivating episode from the Journal Club series that we started. And today we have Uvea. And yeah, so the publish or perish, a call to action was the theme of how we started this. And this is the team headed by Dr. Devakant Mishra, sir. And this is the team that is doing tireless work behind them, along with them. The concept of this YOSI Journal Club is to learn and grow. And we made sure that we cover the YOs at all levels. A PG first year, second year, third year, and a fellow. So the idea is we didn't want to miss out on any facet, and we have curated the journal club in a customized manner. And it is to assess the research literature from a problem point of view, a research question point of view, the variables, subjects, analysis of data, and the interpretation of the results along with the MARI questionnaire. And this was a format that was devised by our predecessors, and Dr. Anujit has been very instrumental in taking it forward. And I was actually later to join the team. And this is the format: the presenter, and then the mentor, the moderators, along with the research experts that we have today. And recently, we have started the keynote speaker as well. So the MARI method was M for method, assignment, assessment, results, interpretation, and extrapolation. So the dissection happens at all levels. And currently, myself, Dr. Prasanna Venkatesh Ramesh, is in charge, along with Dr. Anujit and Ayushi and Naranjan, who are the core members, along with an extensive team who is doing this wonderful job. For anybody who's watching this, if you guys want to see the previous work done by us, you can just scan the QR code here, and it will directly take you to all the previous YouTube links. And if you're interested to be on the other side as a panel or a presenter, just mail us and ping us on the WhatsApp or the email ID. And it's an all-inclusive journal club. You can also be on the other side, and that's the whole idea of YOs participating and deliberating. So just express your interest by filling out the Google Forms that you see, or by shooting a mail to us. And the history of our journal club in 2021, as you can see, Dr. Sonal was also very instrumental. We had 4 episodes in 2021, 5 episodes in 2022 under various specialities. And in 2023, we had close to 7 subspecialty episodes. It kept increasing. And not only that, in 2023, we had our first IGO collaboration with the IGO editor, Dr. Vanati ma'am. And then in 2024, we had 6 different capsules of how to write an original article, how to do a case report, how to do a photo essay, avoiding plagiarism, publishing and beyond, and all different aspects which are not covered, or it's more like an untold story. Recently, we had one on mastering research in ophthalmology. Along with that, the subspecialty even continued. We had around 4 capsules of it. And in 2025, we had a biostatistics webinar exclusively for it, and we roped in one of the senior most biostatisticians, retired HOD of AIMS, Dr. R.M. Pandey sir. And this is the 2025 that you can see. We made sure we covered all facets and discussed and deliberated each paper. And we were lucky to have some stalwarts like Srinivas K. Rao sir, Dr. Siddharth Dikshit, and Dr. Supriya Dabir ma'am. And today again, we have an elite panel that brings us today, where we are going to have a development of classification criteria for uveitis. We are going to deliberate and discuss on it extensively. So with that, I would like to hand over to Dr. Anujit, who has done extensive work for YOSI in the Journal Club and beyond, to invite the keynote speaker of the day and start the proceedings.
Thank you. Thank you so much, sir. And it is indeed a pleasure to be hosting Journal Club. I think this is one of
my favorite educational activities that YOSI does on a monthly basis. And it gives me great pleasure to introduce today's keynote speaker, who is none other than Dr. Parthopratim Datta Mazumdar, who is a one name in uveitis, not only in the country, but also outside it. He is a professor as well as senior consultant in the Department of Uvea and Intraocular Inflammation at Shankar Nethralaya, Chennai. Completing his MBBS and MS from Silchar Medical College, he completed his fellowship in medical retina and uvea from Shankar Nethralaya. He has too many awards to his credit and too many academic roles as well as publications, but I will just name a few. He is a recipient of the TLK Rao Endowment Award for Best Associate Consultant, as well as the Nataraj Pillai and KR Datta Awards for Best Paper Presentations. He is also a section editor at Indian Journal of Ophthalmology. And for all postgraduates and young ophthalmologists, we lovingly know him as the founder as well as the editor-in-chief of one of the greatest educational pages in ophthalmology, which is eophtha.com. He has 220 plus publications, 56 plus book chapters, and has been an editor of 3 ophthalmology books. His clinical and research focus currently focuses on uveitis, scleritis, as well as phacoemulsification, uveitic cataracts. He has a lot of research on biologics, JAK-STAT inhibition, pediatric uveitis, and ocular TV, with extensive publications as well as review articles in more recent years. And he is a speaker at national and international conferences, and he leads a Uvea for All CME. And most importantly, he is loved, revered, and respected extensively in the world of Uvea, as well as by junior ophthalmologists as well as his students. Sir, can you move on to the next slide? We can go ahead with the speaker after that. Um,
1 second.
yes, sir, of course. So he has, just to inform everyone, that Sir has also been extremely instrumental in conceptualizing this particular webinar where we are dealing with Uvea. And then we move on to the presenter, who is Dr. Fatima A from Shankar Nethralaya. She has completed her UG from Kilpauk Medical College in Chennai, as well as her PG from RIOGOH MMC in Chennai. She's currently pursuing her fellowship in Uvea Medical Retina at Shankar Nethralaya. And needless to say, under Sir's mentorship, she has already published a lot of articles. With that, Dr. Fatima, you can share your screen and go ahead with your presentation.
Yes, sir. So is my screen visible, sir?
It's not visible to me right now. You can just reshare the screen. Yes, now it's visible. You can go to full screen. Yes, you can start.
So good evening, everyone. I'm Dr. Fatima, and I will be presenting a journal discussion of the article Development of Classification Criteria for the Uveitis, published in the American Journal of Ophthalmology by the Standardization of Uveitis Nomenclature Working Group in the year 2021. So the agenda of today's session will be like what is the actual current knowledge about this sun criteria, followed by introduction, purpose, the methodology, research, and discussion of this article, followed by analysis of this article with the Mary format. So the current understanding of this sun classification is that sun has already devised a uveitis classification on the basis of its anatomical location as well as its etiology. So why we need another article? So what this article is exactly about is that the classification criteria, which is the important protagonist of this whole session. So what is this classification criteria similar to a diagnostic criteria, or if they are different? So let's see that. Classification criteria is the one that is used to diagnose the diseases for research purpose, whereas the diagnostic criteria is the one that is used for clinical purposes. So both seek to minimize misclassification rates, but when a trade-off is needed, the classification criteria leans more towards specificity in order to make the research tools more homogeneous for analysis, Whereas diagnostic criteria leans towards sensitivity in order to avoid mistreating and in order to avoid missing out any treatable cases in clinical care. As of now, even though there are multiple diagnostic criteria available, there is no validated systematic approach to classify the uveitis. And also, the current agreement among the uveitis experts on the diagnosis of a specific case is just moderate to best. And owing to this lack of uniformity of reporting in literature, there is an uncertainty about the comparability of the different case series and clinical studies that is available at present. So the purpose of this SUN classification criteria is to develop the classification criteria for 25 of the most common uveitis using a formal approach to development and classification. So they have actually spaced out the methodology in four phases. The first being the informatics, because describing the cases is actually the first important step before going on with the analysis. So they have standardized the vocabulary and set of dimensions to describe these uveitic cases. So this will help in maximizing the discrete data collection and also minimizes the free text. So followed by this informatics phase, they have moved on to the case collection phase, wherein at least 75 contributing investigators have contributed to around 5,766 cases of 25 of the most common uveitis, and this were retrospectively collected between the years 2010 to 16. So followed by case collection, they formed a preliminary database. So from this preliminary database, a final database was narrowed down by means of supermajority agreement on the diagnosis of the conditions, which was reviewed by a committee of 9 investigators. So once this final database is actually formed, they have divided this final database into a training set as well as a validation set, including approximately 85 percentage of cases in training and approximately 15% of cases in the validation set. So once this is actually formulated, the sets were used to determine and validate the classification rules and using statistical models. So those statistical models were employed through a machine learning stage, and various classification methods were considered, of which the most relevant to this analysis was multinomial logistic regression with lasso regularization. So this was used to identify each of the predictors which was associated with the outcome. So by this method, they have devised the classification rules as a linear combination of features. And these features were actually restated as Boolean expressions. So why such a conversion of that to Boolean expressions is needed is that, so once machine learning actually identifies the features, obviously it produces equations like log odds of the disease. So equations always is a nightmare. So, and it cannot be used by the clinician for the purposes of the research. So this is converted into human usable rules like Boolean expressions of yes and no features in order to be easily understandable. So, for example, let's take sarcoid uveitis. So, there will be various features which can suggest a sarcoid uveitis in a patient. So, when instead of giving it as separate variables, they have used this Boolean comparison expressions to say as a single entity of evidence of sarcoidosis. So, in each of this criteria, they have included a variable of evidence of compatible uveitis syndromes in order to categorize the diseases. And once this analysis was done with the machine learning statistical models, the accuracy of the final rules were actually tested by means of using a masked observer. So this masked observer was actually asked to categorize the disease, asked to categorize the diagnosis from approximately 10% of the sample of each of the disease in the final database. They were randomly selected, and it was actually the original case data instead of the engineered variables which was formulated by the machine learning. So by this way, the accuracy of the final rules were estimated. And also the masked observers results were compared with that of the machine learning results and also with that of the consensus diagnosis which was actually present earlier. So coming to the results part, of the 4,046 cases, it was distributed into five uveitis classes, namely the anterior, intermediate, posterior, pan-uveitis, as well as infectious posterior and pan-uveitis clubbed together. So In this, the accuracy of the validation set was approximately more than 90%, and it was highly. So this table actually shows the validation set criteria of the 5 UVIT groups. So if you see, the accuracy is actually more than 90%, and the balanced accuracy is also more than 90%, with intermediate uveitis having the highest diagnostic accuracy. And if you look at the confidence interval, all the UVIT groups have a narrow confidence interval, with the most significant being the intermediate uveitis. So this indicates a reliable performance of all these criteria for distinguishing between the different uveitic types. So coming to the accuracy of final rules in the random sample, so the masked observer results were compared with the machine learning and the consensus diagnosis. So still the accuracy stands more than 90%, and there was actually a strong diagnostic performance across all uveitic groups. And most importantly, the accuracy versus the consensus diagnosis was more compared to that of the machine learning methods. So based on this results, the classification criteria was formulated, and the Sun chose a model which was similar to the International League Against Rheumatism, that is a set of required criteria and exclusions for each of these diseases. So this enabled the Sun group criteria to perform reasonably well in distinguishing between the diseases. And important another point to note is that the analysis was done within the uveitic class. Because in terms of classes, the diagnostic confusion will occur within the class and not between the classes. So this approach simplified the analysis to a greater extent. And another point to note is that certain diseases like syphilis, sarcoidosis, and TB tends to appear in more than one class across the 25 uveitis classes. So they were analyzed separately in each relevant anatomic class, and for all the diseases, the traditional nomenclature was actually retained to maintain the consistency. So coming to the limitations stated in the study, so one thing was that it was a retrospective design. So hence, as per the selective Bayesian approach in clinical care, not all tests are performed for all the patients. So hence, there is susceptibility to missing data and variability in documentation. So the next limitation was database transformation error. So as I already stated, there will be conversion of this machine learning variables into usable rules, into clinically usable rules. So this might introduce error during the conversion into the system. There were certain limitations that were resolved in this study. One was selection bias. So the selection bias was actually negated by a reasonable by performing a collection of adequate number of cases with regional variability in incidence. And the next thing was exclusion criteria. So, as I already stated, not all tests will be performed for all the cases in retrospective studies. So, when this test is not performed, the test does not exclude the disease for reporting purposes, but the result consistent with an exclusion criteria does. So, to state this with an example, because it is quite confusing, if a patient with CMV anterior uveitis, they have mentioned exclusion criteria as syphilis serology. But if PCR is done and it is positive for CMV, the patient can be diagnosed with CMV anterior uveitis, even though syphilis serology has not been performed. And another result limitation was that accuracy. So accuracy is actually a weighted average of the sensitivities in a group. So if suppose this will be actually dominated by the disease which is more prevalent among the group. So hence, in order to improve this limitation, balanced accuracy was calculated for each of the disease class. So then next resolved limitation was exclusion of cases during the case selection phase. So since it was excluded in the cases which does not meet the criteria were excluded in the case selection phase, the Sun classification criteria clearly stated that this study cannot be used for clinical purposes, because even though if a patient presents with certain features which does not meet the criteria, based on clinical grounds, the patient can be diagnosed with a particular disease, but the same patient cannot be included in the research studies in order to maintain the homogeneity. So the future directions of this Sun criteria is that it is expected to upgrade with several newer information as the investigative modalities develop and as it becomes available. The classification criteria developed by the Sun Working Group seems to perform sufficiently well for use in clinical and translational research. So now let's begin the evaluation of this criteria with the Mary analysis. So methodology used by this study was a multi-center retrospective study with consensus-based case selection, and it was followed by machine learning. The cases were assigned based on supermajority consensus among experts, and the assessment was clearly done initially with internal validation, followed by independent masked validation, and then balanced accuracy measures were used for assessment. And the results were highly accurate across all the disease categories. And the criteria was more specific and generalizable for research classification with better uniformity when compared to that of the current consensus agreement. And this study can be extrapolated because of its strong generalizability due to global case sourcing from at least 5 continents. So my take is that the future trials can stratify or randomize based on this undefined criteria in order to improve their studies reproducibility. And another point is that this criteria may serve as a reference for the future AI tools in order to categorize the disease likelihood. This classification criteria is not just a single article, but it is actually divided that each of the 25 diseases is published as separate articles, and the salient features for each of this criteria for how it differs from that of the earlier classification or diagnostic criteria that is available is that in case of HLA-B27 associated uveitis, the presence of HLA-B27 positivity or hypopion uveitis was not considered as a differentiating feature. And in case of JIA-associated uveitis, if a child with ANA positivity and chronic anterior uveitis presents, even on follow-up, if the child does not have a JIA, it does not include in the criteria for JIA-associated CAA. And enthesitis-associated arthritis has been included as a JNA subtype by ILAR, but this, owing to its presence of an acute anterior uveitis as manifestation, was excluded from the Sun criteria. And in case of TINO, renal biopsy is stated as mandatory earlier, but in the Sun criteria, the laboratory evidence like elevated serum, elevated beta 2 microglobulin, or presence of altered renal parameters with an elevated serum creatinine is considered as an diagnostic criteria other than if renal biopsy is not performed. And another criteria of anterior uveitis, that is Fuchs uveitis. In the absence of CME PCR positivity or characteristic endothelial lesions, the Sun states that Fuchs remains the default diagnosis. In case of HSV anterior uveitis, in comparison to the earlier heads, the serum antibody positivity is not included in the Sun criteria owing to its poor positive predictive value. And even though there is absence of sectoral iris atrophy, the HSV anterior uveitis can be diagnosed with the help of if there is presence of HSV keratitis or PCR positivity. And in case of VZP anterior uveitis, owing to their database having even bilateral cases of VZP anterior uveitis, they have mandated the PCR testing positivity in conditions where it presents bilaterally. And in case of CMV anterior uveitis, unlike HSV or VZP, which requires only morphological features for diagnosis, CMV anterior uveitis requires criteria requires PCR positivity when clinical picture points to it in order to include the case in the diagnostic include the case as a in the classification criteria. So coming to intermediate uveitis, Sun criteria has included 3 diseases in this intermediate uveitis. One is pars planitis, second is intermediate uveitis of non-pars planitis type, and multiple sclerosis associated intermediate uveitis. So in this classification criteria for these intermediate uveitis, an important point to note is that they have included 2 exclusions. One is positive serology for lines, another one was evidence of intraocular lymphoma and diagnostic vitrectomy. So it is not always possible to do a vitrectomy in all cases to rule out an lymphoma. So they have stated that the vitrectomy is not required for diagnosis unless clinical suspicion of lymphoma is noted. And positive line serology, if present, excludes the pars planitis and multiple sclerosis associated intermediate uveitis owing to its overlapping features between these diseases. So coming to the posterior uveitis entities of AP-MPP, the Sun has subclassified them as eye-limited or with systemic features like cerebral vasculitis. But when mentioning systemic features, they did not include prior viral illness. And in case of mutes, the criteria applies to only early active mutes. The Sun per se is actually including diseases at the time of presentation. So those which are actually resolving spontaneously or those which actually have a late progressive presentation were not included in the classification of these diseases. And even though ICGA finding was suggestive of mutes, they were not commonly used as a criteria under the Sun classification. In case of serpiginous choroiditis lesions, usually they abut the optic disc, but but not always. And those cases were mistaken for multifocal choroiditis and panuveitis. So FFA and FAF are included in this criteria. And this serpiginous choroiditis and relentless placoid choroiditis are classified separately unless further data suggesting them as a spectrum is actually awaited. And in case of posterior uveitis of PIC and MFCPU, some view both of them as actually variants of a single disease, but the Sun working group defines them as separate conditions, acknowledging an occasional overlap. In case of birdshot chorioretinopathy, per se it's rare, and even rare scenarios of uncertain clinical findings, but a classical ICGA, this particular finding is also included in the criteria. In case of pan-uveitis entities of VKH, they also categorized them as early and late VKH, and EDA-OCT, even though it is an important diagnostic tool in VKH, was not included in the criteria. In case of sympathetic ophthalmitis, not much of changes, but owing to it, in conditions where there is no view of inciting eye, they have mentioned that the inflammation in sympathizing eye is considered for classification. And in case of Behçet, similar to HLA B27, the presence of B51 or hypopyon uveitis is not a differentiating feature. So coming to the infectious posterior and panuveitis entities, toxoplasmic retinitis with Goldman-Whitmer coefficient analysis did not emerge as a useful factor in Sun criteria. Hence, serum IgM or PCR is considered for evidence of infection. So in case of ARN, the peripheral necrotizing retinitis rather than rapid circumferential progression is included in the criteria. As I already mentioned, the progression is not analyzed, only the presentation findings are analyzed. CMV retinitis, an important point is that this Sun criteria describe CMV retinitis separately from that of acute necrotizing retinitis. And in case of this CMV retinitis, active retinitis is actually used in the criteria rather than the healed scars. So coming to the tuberculous uveitis, PCR is actually an useful diagnostic tool in ocular TB, but owing to its low sensitivity, that is, they cannot rule out a disease. Hence, it was not included in the criteria. In case of syphilis, the results of the serological testing need to be interpreted in the context of history of treatment for syphilis. Since the presence of treponemal positivity doesn't mean the patient has syphilitic uveitis. And in case of sarcoid uveitis, the probable and possible cases were not included, and the investigations of elevated serum ACE as well as serum lysozymes are only used for exclusion rather than inclusion of the disease. And whether the CT or chest X-ray superior is not clearly stated in this criteria. So thank you for listening. I would like to thank Partho sir and the YOSI Journal Club for providing me with this opportunity.
Thank you so much, Dr. Fatima. So I think this very much coincides with Partho sir's style of presentations. So I still remember as a postgraduate in one of the CMEs when we attended, sir was speaking about some 10 points, and that 10 points happened to cover the most vague topic of uveitis. So similarly, sir has chosen a very fantastic article that gives us a wonderful overview of uveitis. Sir, have you joined us?
Yeah, sir is here. Sir is here.
Yes.
Partha sir is here.
Partho sir, your comments on the presentation and your perspective, sir.
So the
We
reason
welcome, we welcome you, sir, on behalf of YOSI Journal Club once again. Thank you for your time, sir.
Yeah. So I thought that this is something very new in Uvea it is, and two three things you need to understand from here is that the sun classification was the most influential classification in Uvea it is when they came up in 2005. So if you see the anatomical subtypes, even we try to categorize inflammation with cells and flare, all we follow their classification. But this set of, if you see these articles, no, there are 30 articles were published in American Journal of Ophthalmology. So any of you want the full text of these articles, you can actually mail me or Fatima. So we'll be happy to share this article. So two, three things you need to know about this article. These articles are brilliant ready reckoner for each entity. So if you read the discussion part of this article, I won't suggest because the sometimes you have a lack of time and all. So the discussion part of the article is very crisp summary of each clinical entity, so which can be helpful. Second thing, that don't think that like 2005 sun classification, this sun classification articles are diagnostic criteria. These are mainly can be used for research methodology, not for day-to-day in clinical life. I'll give example. For example, like for diagnosis of Fuchs uveitis, they have recommended to do a lot of tests. And we know that Fuchs uveitis is a diagnosis of clinical diagnosis. So many of these articles, though it is widely available, and sometimes in scientific discussions, people will be quoting this article telling that these are the diagnostic criteria. But in practice, these are the mostly used for the research purposes. Second thing, you will observe that the predictive, if you see that statistical analysis, this part of the study, you'll see that the artificial intelligence was introduced to analyze the various form of uveitis, and they were not exactly successful in doing that. So there was a lot of actually pitfalls in this that entire criterias and all. But it's a very good information or very essential these things you people should go through it, and I think it will be useful for all of you to understand that means what all happening in the uveitis. Few things you need to understand is, I think Fatima already nicely explained that for example, ARN, earlier we used to think that ARN is, if you see any read textbook, it is said that the ARN is caused by HSV, VZV, and CMV, whereas in this criteria, they have tried to actually separate the CMV from the ARN. So according to them, if you see a case of ARN-like picture and CMV is the causative organism, then better to term it as a CMV retinitis. Second thing, that they have removed the hypopion or HLA-B27, rather giving importance to the clinical phenotype. Because we know in our clinical practice, sometimes you see a case of unilateral anterior uveitis with a lot of fibrinous reaction. Hypopion may or may not be present. Patient typically gives some history of backache. So you think that it is a HLA-B27 associated uveitis, and the HLA-B27 test comes negative. So this is very important to understand that HLA-B27 is not always essential to diagnose a case of HLA-B27 associated uveitis, because this biomarker can be negative at presentation and can be positive after a certain period of time. So these are the various things are there. Little can be discussed for a long time, but I think this is the main crux of the these articles. There are 30 articles which Fatima tried to actually consolidate in this 15 minutes of this thing. Thank you, Fatima. I think you did a wonderful job.
Thank you. Thank you so much, sir. Thank you for those valuable inputs. I think we have a very clear clarification on the classification and its importance and how it is modified over several articles. Now I request Dr. Ayushi to introduce the panelists for today, who will be sharing their expert opinions on this presentation. Over to you, Dr. Ayushi.
Thank you, Dr. Niranjan, and thank you, Dr. Fatima and Dr. Parthu Pratim sir, for the wonderful insights and the presentation. It is my pleasure to introduce our three panelists for today. So first we have Dr. Karpagam, uh, who is currently a cataract and uveitis specialist at Dr. Agarwal's Eye Hospital. She's also the dean at the Agarwal's Institute of Optometry and also serves as a chairperson of their clinical education committee. She has finished her fellowship in uveitis from the prestigious Shankar Nethralaya from Chennai. Welcome, Dr. Karpagam. Then we have Dr. Jonathan Chavan, who is currently a consultant in the Department of Uvea from Arvind Eye Hospital, Madurai. He has done his Uvea fellowship from Arvind Eye Hospital and Postgraduate Institute from Madurai. Welcome, Dr. Jonathan. Then we have Dr. Eliza Anthony. She has been a consultant in the Department of Uvea at Arvind Eye Hospital, Chennai for over 8 years now and has extensive experience and expertise in the subject. She has done her fellowship in Uvea and medical retina from Shankar Nethralaya, Chennai, and had finished her DNB from Giridhar Eye Institute at Kochi. She has also won several awards, including the Best Poster Award in the recently concluded APO AIOS Uvea session, and has also co-authored several book chapters, including ocular sarcoidosis and TB. Welcome, Dr. Eliza. Now, I would like to request our panelists for their comments on the article and the presentation, as well as the topic in general. Over to you, Dr. Karpagam. Would you like to comment?
Yes, thanks, Ayushi. And first of all, I'd like to congratulate Prasanna and Niranjan for coordinating this session. It's really wonderful that these platforms, happen on a regular basis for us to update. And in fact, I think today's session was an update even for me. So thanks to that, and to witness a visual treat when Partho sir, kind of handholds you for the presentation, it's clearly visible. The way Fatima presented and consolidated the points. If you try to go through a paper, you need to know the nuances of how exactly to go about reading the paper and how to pick up the points so that you go back home, consolidate it, and take up some message. It should not end up getting confused with the numbers and the data and how the statistical analysis is done. So I think Partho sir already kind of summarized what you have to learn. This paper is not going to give you the key inputs about how to go about diagnosing a case. It is not going to be used for your clinical diagnosis. This is going to be more useful if you're going to be interested in your research, in your publication, a clinical trial. We need to take those inputs because, as uveitis, there's going to be a lot of overlap between the way the signs and symptoms present, and most often the experts do not agree. So what was happened was, if you want to go about conducting some kind of research trial, you need to know whether these experts are talking with the same case in mind. And that is why this study was born. So I think towards the end, when she consolidated that there are certain norms which were in agreement before we started. But later on, as we progressed, things started to change. Uvea has always been an enigma, and that is why probably every one of us gets attracted to Uvea. And it may still remain an enigma in the sense that when Partho was telling that most of the time it's a presumptive diagnosis. We don't really have, even we would like to have, 100% diagnostic test, which is going to make the doctor and the patient happy. But unfortunately, more than 50% of the cases we still do not have. It is most commonly a working diagnosis. This is not going to make a doctor happy if you want to treat the patient well. But for us to come up with certain working criteria so that we go about understanding how the disease behaves and how we can do a research platform. I think this is where the study stands at. So this is my take on it. And I would like the other panelists also to comment on this.
Dr. Jonathan, are you there?
Yes, I'm here. Yeah. So I would like to begin by saying that this article was very well presented and very well summarized, like all the disease entities at the end being summarized was a really good job. And thanks to Dr. Fatima for her hard work. So, yes, so as said earlier, we do rely more on clinical assumptions when we treat uveitis rather on the diagnostic criteria. But I feel that it helps to form a foundation that is needed to help the clinician to treat the disease. And especially with AI coming up, as said in the presentation, AI will mostly rely on these criteria that are published to help form, and it will help to be an educational tool later on, as many future ophthalmologists will use it. So, those are my inputs on that. Yeah.
Thank you, Dr. Jonathan. Dr. Eliza, would you want to share your 2 cents as well?
Yeah, a very good evening to everyone, and I thank Yosi for inviting me for this amazing session, and even Dr. Partho for making me a part of this. And Fatima, I would really like to congratulate you. Presented this journal very well, and especially I think most of the clinical points she has compared during the presentation. And even Partho sir has told this journal is very good for research purpose, especially the algorithms, how they have used and how they have classified to develop the platform and thinking process, how you would plan a study, especially a simple thing like classification criteria. I would just like to say few points regarding like as you read the journal, you would have seen many times they have written that as it was done in multi-centric study, many of the data were not available. So when there was an absence of data, they have called those data as negative. So that is one point I would say, that such a large study, if you call a data negative, maybe it does not signify the absence of disease, and it could have led inflated the specificity of the classification criteria, because the absence of data does not mean the disease is absent. And many times there can be co-infection, like toxo and TB can come together in the eye. So that is one thing which has been included, the absence of data negative. Another thing is definitely it has covered many centers, but I just noticed the distribution, the table that they have given. If you see, intermediate uveitis cases were only 2 from Asia. So actually, if you're talking about common uveitis, intermediate uveitis is a very, very common thing that we see. So that is another point that I would like to highlight when you're using a classification. I think the distribution from the Asian countries was not very uniform. So that could lead to a bias considering this sun classification. It's a very, very beautiful study, but just that distribution, the geographic distribution, I felt the cases from few places were not uniform, so that could lead to a bias in this. Again, a last word about PCR. Again, as she told, that the PCR is often misleading. Many times we think it's ARN, but the PCR comes negative, and sometimes PCR comes positive, and then it turns out to be sometimes like retinitis, like looking T cell lymphoma, and you have got a positive PCR for HSV. So that is something a human brain can assess, but when you are relying on AI and a machine, you have to be very, very careful in developing classification criteria. However, as sir told, this is mainly just for research purpose, not to be used or considered for a diagnostic tool. So these are just few points I wanted to tell as I went through the journal. Thank you.
Thank you so much, Dr. Eliza. Dr. Anujit, would you like to comment?
I think they've summarized it really well. We can move on to sir.
Thank you, Dr. Aishi, for moderating the panelist's opinion. Uh, so with that, can we move on to the keynote speaker for today? So it is indeed my privilege to introduce one of the stalwarts in the field of Uvea. So Dr. Partho Pratim Datta Majumdar. So he has completed his MS and MBBS and MS from Silchar Medical College, fellowship in medical retina and Uvea at the prestigious Shankar Nethralaya. Sir has several awards and honors, academic roles, publications, and has participated as speaker in several conferences, both national and international. It is indeed a privilege to have you with us as a keynote speaker for today evening's program, sir. Over to you for your keynote lecture.
Thanks, Niranjan. 1 minute. I'll just.
Yes, sir. Yes.
Yeah. My slides are visible.
Yes, sir.
Yes, sir. Yes,
Yes,
sir.
sir.
Visible, sir.
So, good evening, everyone. So, all of you must have seen this topic I have selected. So, this is actually inspired from that 7 deadly sins, which is a very excellent concept from a Christian moral teaching or philosophy, which are considered to be the root of immoral behavior. So similarly, in your clinic, these are the deadly, not scenes, deadly signs if you miss in your clinic, no? So sometimes you can actually land up in a problem. So I have tried to summarize it with a little punch from the basic science also, because you people will be the best audience to discuss a little bit of basic science and the clinical implication of those, so that you can be little careful, because many of them, like I do, I mostly try to see the uveitic patient. You have see various other specialty, and some of you are seeing uveitis as well as many other subspecialties. So it will be very, I think it will be a ready reckoner for you. So to start with, I'll go directly with the sign. So if you first look at my first sign, here you can see. So there are 6 pictures, 6 little photographs here. I have not included conjunctivitis in this picture because I'm sure that all of you are aware how to differentiating conjunctivitis from other causes of red eye. But one thing you must realize that some conjunctivitis can be associated with uveitis. For example, the purulent conjunctivitis can be seen in reactive arthritis, formerly known as Ritter syndrome, and psoriatic arthritis. Similarly, the subconjunctival hemorrhages can be seen in patients with leptospirosis. And sometimes there are reports that the vaginal granulomatosis can have a conjunctivitis-like picture. So these are the things you have to differentiate. Now look at this 6 slit lamp photograph. If you go to the diagnosis, the first photograph is episcleritis. The second one is hemangioma. The third one is scleritis. Now, how will you differentiate between scleritis and episcleritis? I'll come to that. And another close mimicker of scleritis-like picture is CCF. So this entity, why it is similar? Because they usually present with severe headache, and sometimes it will be reflected in your clinic as a severe pain, eye pain, and they can have some congested vessel, classically described as corkscrew vessels. So these are the differentiating point from that. Then we have ocular cicatricial pemphigoid and nodular scleritis, which can come to your clinic with redness. Now, if you see the anatomy of that, the anterior ciliary arteries, if you see the course of that, it travels along the tendon of the rectus muscle and gives off anterior conjunctival arteries just before piercing the eyeball. Now, if you see the discourse of that anterior ciliary arteries send branches to the precorneal plexus and to the surrounding region of the bulbar conjunctiva in the limbal area. Now, these are the vessels predominantly involved during the ciliary congestion. On the other hand, if you look at the conjunctival congestion, the ascending branches of the peripheral tarsal arcade, where you see there peripheral tarsal arcade, so they actually travels and that pass on to the superior fornix that continue into the fornices of the bulbar conjunctiva as posterior conjunctival arteries. Now, in conjunctival congestion, these vessels are congested and involved. So, conjunctival congestion mainly seen in the fornices, and the ciliary congestion is mainly seen in the near the limbus. So now if you see that when you dealing with a case of scleritis and episcleritis, sometimes it's very difficult in your clinic that because some patients in India, what happens, most of the patients that they perceive any ocular symptom as a pain. So you need to ask a leading question to differentiate it from discomfort or pain. Because if you ask a patient of episcleritis who is suffering from ocular discomfort, that whether he or she is having pain, the first question will be, first answer will be, yes, I am having a pain. So you have to ask a question, leading questions like, have you taken analgesic for your eye pain? Or is there any, the amount of the severity of the eye pain is so much that you had to wake up from the sleep? So these are the questions you can ask in patients with episcleritis or scleritis in confusion to differentiate them. So the presence of pain is very important, which can be seen in scleritis, and severe tenderness. A typical scleritis patient won't allow you to examine him or her properly. So so much is the tenderness. Second thing which is very useful in your clinic is just apply a drop of phenylephrine, which is a vasoconstrictor. So if the vessel blanches with that, so you can see, you can say that it's a episcleritis. Whereas in scleritis, the vessels won't blanch because these are deeper in the layer. You can see in this diagram, the deeper episcleral vessels are located here, and the episcleritis, where the superficial vessels are involved, they are located here. So this is a very practical and very useful tool in that differentiating a scleritis, that applying a drop of phenylephrine. Even now also I rely on this technique because it is very useful in your clinic. Now, when you talk about the congestion and you try to actually understand that what are the causes of that, you know that you have to look for the chemosis. As I mentioned, the vaginal granulomatosis and some kind of systemic association can be seen in patients with uveitis who can actually present initially with chemosis. Now, the discharges are very common in conjunctival inflammation, very rare in scleritis, episcleritis, or in case of uveitis. So it is always useful to look for the discharge and examine the fornices. And as I said, the topical vasoconstrictors are very important. But when you are delineating history or asking questions, make sure that you are taking a history of anti-glaucoma medication like brimonidine-induced uveitis. It typically involves the palpable conjunctiva, and there will be some conjunctival inflammation, and there will be minimal anterior chamber reaction. Similarly, the prostaglandin-induced uveitis, they may have little bit of congestion, and the keratic precipitates and anterior chamber reaction can be seen. Now, also, you have to remember that uveitis can occur without congestions. So don't miss the white eye uveitis. Most of the time we miss a diagnosis of uveitis because it is absent, congestion is absent. So what are these conditions? These are the pars planitis, the Fuchs uveitis, juvenile idiopathic arthritis, white dot syndrome, and toxoplasmosis and toxocariasis, and masquerade syndrome. So most of the time what happens, initially they may have a very minimal congestion, and this patient can go to another ophthalmologist and starting them on topical steroid, no? So there will be absolutely no congestion, and you miss the diagnosis if you are not careful and not examining the fundus. Now, the keratic precipitates is my second sign. It is very important to look for that. As you know, there will be blood aqueous barrier breach, and this cellular components will come out in the anterior chamber. And when you come out, they come out in the anterior chamber, you can see there is a warm iris. So the aqueous will rise because it is a warm, and then they will come in contact with the cooler cornea, and then again they will actually come down. So there will be a convection current like this, and that's why the cellular deposits are seen in a base down triangle like this, which is known as the Earl's triangle. So now this keratic precipitates has certain clinical phenotypes or morphology. Based on that, you can actually presume that what is the pathology. For example, if you see the mutton fat keratic precipitates, you can think about most commonly the tuberculosis or sarcoidosis. But remember that two things, that mutton fat capitis does not mean that you are dealing with a case of tuberculosis. Mutton fat capitis can be seen in viral anterior uveitis also. So there is no, these are not the telltale sign of any particular type of uveitis, just some clinical signs which can aid to your forming a diagnosis or identifying a clinical phenotype. Similarly, the sarcoidosis, that there is no particular point. So you have to remember that why this classification did not gain that much popularity, though it is a very important classification that differentiating granulomatous and non-granulomatous. So this was actually proposed by Alan Churchill Woods. So that's why it is also known as Woods classification. Now, why Woods classification is not that popular, that you can see the patient in slit lamp and you can tell that it is granulomatous or it can be non-granulomatous. The reason is that there are certain clinical entity. One classical example is sarcoidosis. So sarcoidosis sometimes can present as a granulomatous uveitis. Sometimes it can present as a non-granulomatous uveitis also. So these are the different. You have to understand that you cannot actually identify a disease just by looking into the granulomatous or non-granulomatous aspect of that particular disease. So you have to correlate with other finding like fundus finding, laboratory investigation and all. Now, coming to the small and medium-sized keratic precipitates, is very difficult to categorize a particular entity on that. Any kind of uveitis can have a small or medium-sized keratic precipitates, which reflects the size of the inflammatory cells rather than trying to categorize a particular entity responsible for that. But I can give an example that small keratic precipitates can be seen in HLA-B27 uveitis. And then if the keratic precipitates are relatively small but has some extension which make them look like a star shape, so these are called the stellate capes. These are considered as a pathognomic of Fuchs uveitis. But again, when I use the pathognomic word, you have to remember that there are certain viral anterior uveitis can have similar presentation like Uvea anterior uveitis or CMV anterior uveitis. So better not to jump into the conclusion only on the basis of keratic precipitates, though they are very important and relevant clinical signs. Now, pigmented keratic precipitates is a very important condition. So pigmented keratic precipitates can be seen in two conditions. One, burnt out uveitis or an old healed uveitis, where that the uveitis is healed, there is no anterior chamber cellular reaction, and you can see some brown spots in the corneal endothelium, which are actually hyalinized keratic precipitates. That means they are healed by the process of hyalinization, and you can see the pigments over the corneal endothelium. The second one is very important, which is considered as a very important sign for the viral uveitis. That is, there is a active inflammation going on and it is pigmented capes. Now, what is happening? The macrophages, which are roaming in the anterior chamber, they have engulfed the iris pigment, and because of engulfing that iris pigment, they are looking brown in color. So the brown pigmented keratic precipitate with active ongoing inflammation reflects that it is due to viral etiologies. Most commonly, herpes zoster and viral herpes simplex can be responsible for such appearance. Now, coming to that, another morphology is that distribution, how the keratic precipitates are distributed. So the most common is Earl's triangle distribution, which can be seen in any uveitic condition. I must highlight here that the conditions like Bob-Quanagi-Harada disease can present, or sympathetic ophthalmia can present as mutton fat keratic precipitates, and they can have this any kind of distribution like Earl's triangle. But one distribution which is very important and you can pay attention in your clinical practice is that if you see the keratic precipitates as crossing the midline and scattered all over the corneal endothelium, then you can call it that two causes can be responsible for that. One is the viral uveitis and Fuchs uveitis. So any keratic precipitate crossing midline you can think of viral uveitis or Fuchs uveitis. Now, my third clinical signs is that iris characteristics. So, as you know, that there are the ciliary zone and the pupillary zone in the iris, which is divided by the collarete, and there are crypts of Fuchs, which is of great importance for Anujit, Prasanna, and other people who are doing into glaucoma practice. But I'm not going into detail of that. But why I am describing this, that polarity and all other feature here is this because of this Fuchs uveitis. So when we read standard Western textbook like Kansky or Yanov, so most of the time they mention that Fuchs heterochromic iridocyclitis. Whereas in reality, when we deal with Indian patients, this heterochromia is very, very subtle, and most of the time it is absent in Indian eyes who have a darker iris. So here you can't actually diagnose a case of Fuchs iritis based on the heterochromia. So here you have to look for the iris details. Now, what are the iris details? That you have to look for the blurring of these iris clips. You don't see the kind of normal iris pattern you see in a human eye in patients with Fuchs uveitis. So that is more marked in the colarete, the junction of the ciliary and pupillary junction. So that actually gives the iris a smooth and velvety appearance. So this is how actually you can identify Fuchs uveitis. Now, few of you who are trained to see the patient, like your optometrist, do the workup, and after dilatation, the patient comes to you, they caution for them, because you can miss a case of Fuchs uveitis because the iris is fully dilated and you won't be able to see the finer details of the iris. The same with the iris nodules. If iris is fully dilated, then you can actually miss those subtle clinical signs. Now, a few things you need to understand that the viral anterior uveitis. So in viral anterior uveitis, especially the herpes zoster and herpes simplex, these are basically known to cause the endarteritis. So because of the endarteritis, they are known to cause the focal or diffuse necrosis of the iris tissue. So you can see the iris atrophy. Also, you can see my arrow here in the near the pupil. You can see the size of the pupil. So classically, it is called as a D-shaped pupil. So if you see this kind of pupil, which is not round, little irregular in shape, and maybe looking like D or some other alphabet, and the patient is not on any cycloplegic or any other mydriatic anything, so then it's a high time you should suspect that something is there which is destroying the pupillary rough or destroying the constrictor pupillary muscles, and the viral etiology is one of them. Now, coming to the deposits of iris, it is very common because sometimes you can encounter many pathological condition like this. So this, you have to remember one thing, that the iris nodules are accumulation of the inflammatory cells. That is, epithelioid cells and lymphoid tissues are aggregating and making a small mass over the iris. So this iris nodules can be seen in pupillary margin, which is known as Koppe's nodule, and this can be seen in iris trauma, which is known as Busaka nodule. Now, this if you try to differentiate that, how to differentiate between granuloma and the iris nodule, you can see here, this is a picture of iris nodule, and you can see here, this is basically a condition which can be called as a iris granuloma. So these are the conditions, how it differs, the differentiation between iris nodules and iris granuloma. The iris granulomas are actually tissue destruction. Okay, so this is very important actually to understand that this is how it can differ. Now, what are the other deposits over the iris? Now, the iris nodules versus the iris granuloma we have already discussed. So, iris pulse is another important. If you see this glistening material here, then it is actually known as a pathognomic, not pathognomic, it's an important sign of the leprosy. Now, these iris pearls are the small glistening white lesions. This basically indicates the aggregates of tightly packed living and dead bacilli within the mononuclear cells. So these are mainly seen in the pupillary margin around the colarete, and sometimes it resembles a necklace. Now, iris crystals, don't mistake between these two. So here I'm iris crystals. These are basically the immunoglobulin deposits. Now, this can be seen in any chronic uveitis and mostly seen in Fuchs uveitis. So I unfortunately my knowledge with clinic leprosy is very common. I have not seen basically any case of iris pearls in leprosy patient. So my understanding of this iris pearls is from that typical picture in Kansky. I think in South, Ratina ma'am had a lot of published lot of literature. So she will have a better picture of that. I don't have any picture, so I am sharing you the photograph of iris crystal. So these are the basically Russell bodies, which are actually the immunoglobulin deposits and can be seen in any kind of chronic uveitis. The reason I'm telling you that those who have, like me, seen that photographs in Kansky should not confuse this as a leprosy. Okay. So the fourth important clinical signs is vitritis. Now, vitritis, when we talk about vitritis, I remember this line, which I am quoting from the Kansky, which says that that is a sine qua non of the intermediate uveitis. And when we talk about intermediate uveitis, there are most common three causes: ocular tuberculosis, sarcoidosis, and one cause which we often don't pay attention in India is multiple sclerosis. If you search the literature, you will realize that the multiple sclerosis related intermediate uveitis is relatively rare in India. That does not mean that it is actually rare in India. Most of the time, we don't advise investigation to rule out these causes, and maybe when the patient presents very late, they don't come back to ophthalmologist. They start treatment under a neurologist. So that may be my hypothesis, because when we published our series of multiple sclerosis, we had to struggle to find out the references of multiple sclerosis related intermediate uveitis from India. So coming back to that, this thing, so sine qua non of intermediate uveitis in any clinical practice, I think the most biased statement for a clinician. Because if you think that certain condition is typical of certain conditions, you are bound to do some mistakes, because your entire brain will be thinking that yes, your other differentials won't come, and you will be strongly thinking about that conditions management, and your differentials will very, very less, and you are prone to do mistakes. For example, if you see this kind of vitritis in elderly patients, it may not be sine qua non of intermediate uveitis. If it is the patient's in vitritis is coming back when you are stopping the steroid, then maybe you are dealing with a case of intraocular lymphoma also. So don't go by the impression that the vitritis means always intermediate uveitis. Now, why vitreous is important when we talk about that? The one thing is that it's a very good reservoir for anything. Like for any inflammation happening in posterior segment or anterior segment, there will be collection of the inflammatory products or inflammatory cellular aggregates into the vitreous. So that's why the vitritis can be a part of anterior spillover. It can be a part of posterior and panuveitis. So always look for other clinical signs. If you are seeing a case full of vitritis, you can't see fundus, anything, beware. You should not inject any Ozurdex or any intravitreal medication until and unless you rule out what is going on. The reason is that the vitritis can be due to the necrous tissue, debris of inflammation, because the viruses are destroying, like in acute retinal necrosis, all the viruses are destroying the retinal tissue and pouring the entire thing with cytokine, inflammation, all these in vitreous, and you can't see anything. The classical headlight in fog appearance, not necessary every time you will see the headlight in fog. So sometimes it can be totally foggy and you don't know what is going on behind that. So this is very important. In such cases, you should take opinion from others, or you should go ask your vitreoretinal friend to do a vitreous biopsy, that what is going on behind that. So without knowing what is happening in backside of that foggy area, you should not inject intravitreal injection. That is first. Second thing is that the inflammation of the surrounding tissues are important. So any vitritis indicates that it can be sometimes can be spillover from the anterior chamber inflammation also. And anterior chamber inflammation with topical steroid may heal very spontaneously, and the anterior vitreous inflammation or the cells may persist. So you have to be very careful while delineating that. Now, 2, 3 things, if you can see something like, if you see multiple exudates like localized mainly inferiorly, most probably you are dealing with a case of pars planitis. Why I am using the pars planitis? We believe that if you don't find any etiology, we term this term as a pars planitis. And if there is a cause, for example, if you detected a systemic association like tuberculosis or sarcoidosis, then you call it an intermediate uveitis. Now, if you see that confluent peripheral or posterior pole retinitis, it is viral infection. Remember, nowadays that Fatima has nicely discussed that. Nowadays, it does not require to do a multiple examination and see the circumferential spread to diagnose it as acute retinal necrosis. If you see that peripheral confluent areas of retinitis, make sure that you are doing a proper clinical microbiological investigation and ruling out the acute retinal necrosis. Solitary or a single lesion, if you are seeing in the midst of a vitreitis, it is almost always parasitical, protozoal rather, and toxoplasma being the most common cause. If you see any band or dragging, especially in the children, the toxocariasis is known to have such band. So be careful in such conditions. Now, I have already told you that the vitreous opposites and old hemorrhages can be there. And it's very important, sometimes can be confused with some other conditions. So the another infiltration, cellular infiltration, can be seen in clumps like snowball or in chains like string of pearls. So these can be seen mainly in the tuberculosis, intraocular lymphoma, and multiple sclerosis or sarcoidosis. These are not actually a sure shot sign or pathognomic of any particular entity. I have seen many discussion going on, like if you see snowballs or string of pearls, it can be due to sarcoidosis, or so it can be due to multiple causes. And another important dreaded condition is that fungal infections. So you have to sometimes, these are the, you can see here, these are the exudates, sometimes actually called as a rice puff exudates. So this can be actually pathognomic of endogenous endophthalmitis, especially the endogenous endophthalmitis. So if you see this kind of exudates in the fundus with vitreitis, make sure you are ruling out endogenous endophthalmitis. So what are the main actually investigation we do to rule out endogenous endophthalmitis? We send the patient for blood culture. We send the patient for urine culture. We try to do a abdomen ultrasound. Why? Because it has been seen that in Southeast Asia, not in India, Southeast Asia, it is the splenic abscess or the some abdominal abscess or infection which actually can be there in endogenous endophthalmitis. But if you have to remember that endogenous endophthalmitis is an entity which require more than clinical investigation. It requires more chair time. So you need to check with the patient whether the patient has undergone any surgical intervention. It can be a simple tooth extraction or something. So try to pay attention to the simple signs of like whether the patient is diabetic, whether there is any history of any prolonged hospital administration, whether there is any septic foci, some boil or abscess in patient actually. So another point here I want to highlight here is that we ophthalmologists, when we talk about systemic association, our systemic examination means basically a thorough history taking. Because the kind of chamber we have, it's not possible for us to go for a proper systemic examination, and it's not practical also. So these are the patient requires meticulous history taking, and by the history taking only you can actually receive the systemic examination. Now, vitreitis in elderly, already I have explained that it can be due to intraocular lymphoma also. Now, coming to my fifth clinical signs, if you see here, it is a retinitis. So these are the conditions you have to differentiate between choroiditis and all. So there will be a lot of discussion about how to differentiate between choroiditis and retinitis. But believe me, the most common actually tips which helps you in clinic is that just follow the retinal vessel. You follow the retinal vessel, it will give you the answer whether it's a choroiditis or retinitis. You look here, you can see here the vessel, because you can see here that yellow diagram you see here, that is a choroiditis, and you can see the retinal vessel above here. So here is in choroiditis, you can see the retinal vessel and it is behind that. So it is a case of choroiditis. Now you look here, you can't see the retinal vessel, can you? You can't see here, but you see this diagram here. The retinitis is above the blood vessels, so you cannot see the blood vessels. So this is a case of retinitis. Now, how to evaluate a case of retinitis? You have to remember retinitis is almost always infectious. There is no doubt if you are dealing with a retinitis that you are dealing with an infection. Now, how to evaluate a case of retinitis? Think about viral etiology, syphilis, and toxoplasmosis. So in viral etiology, you know that acute retinal necrosis, herpetic retinitis, and CMV retinitis are the common cause. Then coming to the syphilis, when you should suspect syphilis, I will give you the common clinical picture that if you see this kind of ground glass like retinitis, now why it is ground glass? You can see the underneath retina carefully. If it is a herpetic retinitis, you cannot see the underneath retina because it will be fully opacified. So here, if you see this kind of ground glass retinitis with presence of small creamy white superficial retinal precipitates, then this can be a syphilis. So try to always investigate that. Now, coming to that, any kind of uveitis, dealing with anterior chamber, you are dealing with scleritis, you are dealing with intermediate uveitis, always remember or tell your secretary that always to add the TPHA in your laboratory investigation. It can be of any sheer short case of any uveitis, but it is almost always essential to rule out syphilis because it is a great masquerader. Now, little bit of theory again I'll go when I'll discuss the herpetic retinitis, the differentiating between HSB, VZB, and CMB. That HSB, all of you know, CMB is commonly seen in immunocompromised, and HSB, VZB enters through the neurons and typically starts at the periphery at the pattern which corresponds to the termini of the ganglion cells. So this is why the ARN starts from the periphery, and the CMB which enters the eye through the blood, and that's why it is vasocentric. Now, what is the difference? HSB and VZB spreads very fast and CMB is a slow-going organism. So coming to that ARN, I'll try to wrap up a little fast that the confluent retinal necrosis you see, which coalesces 360 degree, and you can see this scallop margins and all. And the optic nerve involvement is my 6th point. You can see the sarcoidosis, leakage. These are the conditions you can see. So if you see this kind of peripheral choroiditis lesion, you have to rule out 3T. These are the Jensen's choroiditis. 3T indicates TB, toxoplasmosis, toxocara. So similarly, the neuroretinitis, it's very important. You remember neuroretinitis is almost always bilateral. Now, coming to another entity with optic disc involvement with subretinal fluid is Vogt-Koyanagi-Harada disease, posterior scleritis, and sympathetic ophthalmia. So all of you know Vogt-Koyanagi-Harada disease will have a lot of inflammation, panuveitis conditions, and in later stages, you can see the vitillaginous patches, you can see the depigmented eyelashes and other signs. Now, the retinal vasculitis is my first, my 7th this thing. So as you know that retinal vasculitis, the shedding is that disruption of the endothelial junctions. I think detailed discussion of the retinitis is another class. So I'll just try to summarize it very in short, so that you have to understand that there will be shedding, which actually can infect the perivascular plates, and there can be involvement of the lumens also. So coming to the practical important points, you have to understand that there is certain retinal vasculitis which only involves the vein. These are the sarcoidosis, most common. Toxoplasmosis, you will see rarely the veins are true retinal vasculitis is there. Most commonly, it is that chiral arteritis. But yes, if the veins are retinal vasculitis is there, veins can be involved. And then coming to the arteritis, the most common is syphilis, any kind of viral etiology, and systemic lupus erythematosus. Whereas the combination of both can be seen in multiple sclerosis, Behçet disease, or granulomatosis polyangioitis. Now, TV vasculitis can be suspected if you see this kind of CRA patches around the blood vessels in a patients with small choroiditis or any other entity. Now, sarcoid vasculitis will be always exudative and never occlusive. So you do a FFA, if you see the occlusion, you are almost sure that you are not dealing with exudative, sarcoidosis. Now, the Eales disease is obligatory vasculitis, and you can see that all investigations are negative, and Eales disease almost always a disease of exclusion. Now, the Kyrillis vasculitis, you see, these are the kind of deposits. These are not true vasculitis because the inflammatory cells will be deposited over the retinal vessels. So that's why they look like inflamed vessels. So that's why it is called Kyrillis vasculitis plaque. Now, prostate branch angiitis almost always indicates it's a compromised and it's a sign of some infection, most commonly CMV and toxoplasmosis and other causes. So coming to my last slide, the 7 take-home message, the uveitis can occur without congestion, especially in children. Remember this is very important. And diffuse keratic precipitate can be seen in fuchs and viral anterior uveitis. Iris pattern is lost in patients with fuchs uveitis. Unexplained vitritis in elderly can be seen early signs of lymphoma, and retinitis is almost always infective. Always rule out the infective etiology, and neuroretinitis is almost always unilateral. And unlike sarcoidosis, TV vasculitis is almost mostly occlusive. Thank you.
Thank you, Parthupratim sir. Even I mean, we were able to learn a lot of things from you today, and I think the take-home message really sums up a lot of things, especially your talk on keratic precipitates, how to go about doing a differential diagnosis, and uveitis happening in pediatric age group without congestion. The 7 take-home messages that you shared, the iris pattern being lost in patients with fuchs uveitis. I mean, I think these are all the most salient points that we would, I think, learn from today, along with the journal club. And any other suggestions from any of the panel on Sir's talk? Dr. Eliza, Dr. Jonathan, you want to add something? You want to share your views? Partha sir, if I can ask you one question before we move to the last agenda, which is the certification that we have in our YOSI platform. So what is that you would tell any aspiring residents, one take-home message, or I mean, again, you have given 7, but what would you say, anything regarding a slit lamp examination to differentiate an active uveitis versus passive uveitis, your take on it, how to go about differentiating? It's a very vague term to put in, but
I think
had this.
I think it's a little lengthy, this thing. One advice, I don't know, as a you can say that as a friend, I can give you one advice: don't fall in love with your diagnosis. I feel it is the most dangerous. Even I have. If I attend a particular talk by someone, if I read a particular topic, there is a constant bias in our brain that we tend to see those kind of condition like more. So, and it's always important to, because we are what means how strong is our differentials, how good clinicians we are. It is defined by our differentials, the ability to rule out the various differentials. That is how actually our clinical acumen is. So I think it's very important. You asked me how to differentiate between acute or old uveitis. Old uveitis, see, it will have a pigmented KPs. There will be very cells with crenated margin in the anterior vitreous, and there will be scarring of the vessels and all. But there is nothing called, see, most important is you can't level a case of uveitis as a chronic or old uveitis until and unless do some investigation. The classic example is retinal vasculitis. Until and unless you have done a fundus fluorescein angiography or seen that there is no leak from the vessel, our naked eye, actually, you cannot tell that. Only the problem is there. We feel that if we see cells, then only active inflammation. If there is no cells, then there is no inflammation, means uveitis. That is not always true. There are certain conditions like we have now started diagnosing is that in Behçet disease, everything is quiet, anterior chamber is quiet, posterior segment is quiet, you can't see any vessels. Your rheumatologist friend has referred you that it's a case of Behçet's, kindly do the fundus examination. Fundus examination look normal, but if you do a fundus fluorescein angiography, you can see the vessels are leaking. So that indicates that ocular vessels are involved, which is not possible to detect with the naked eye. So I think it is always better to do a clinical examination and do some ancillary investigation before you level a case of uveitis as a old uveitis.
Thank you. Thank you, sir.
Yes.
Sir, can I just ask a few small questions?
Yeah, please.
Yeah, Anujit, over to you.
Yes, sir. Sir, could you explain why neuroretinitis you mentioned is mostly unilateral presentation? That is one question that I had. And what are the sure shot conditions in which we would not proceed with further testing or investigations before we consult a rheumatologist? What would be your suggestion for that?
Okay. So I'll come to the neuroretinitis classically, if you see, it is described as a triad of, the definition wise, it's a triad of unilateral vessel vision loss. It is that the macular star and that optic nerve involvement. These are the three important points. Now, why I am telling that you must remember it is unilateral? Because many of the time you'll see that neuroretinitis like picture and it is bilateral. So
Yes,
these are
exactly.
the conditions you have to rule out the metabolic disease like hypertension. You have to rule out the diabetes mellitus, and you have to rule out like any CNS pathology or not. So this is very important to differentiate because neuroretinitis is almost always unilateral. Now, having said that, we recently analyzed our cases of 100 and I think 20 cases of neuroretinitis, and we realized that this is not actually true. That their neuroretinitis can be bilateral in some infectious condition from India. So it is actually very not reported in literature widely. Still, we follow that. But for normal clinical this thing, I feel it is very important to keep in mind that neuroretinitis is unilateral. And if it is a bilateral, first you check patient's BP, you check patient's diabetes sugar level, and look for other, then going to the other signs. So that is another discussion. Second question is very important. Second question you asked is that
Rheumatology opinion in
yeah,
which cases where
this is very important. That what are the conditions you should. So quickly, 2-3 points. Again, I told you no. So if you ask patients that about the joint pain, all our patients will tell yes. Like discomfort, they can't differentiate about. They will have some joint pain. Now the inflammatory joint pains are typically bilateral and symmetrical. It's hardly that only one elbow knee pain is there and other knee is fine. Second is the inflammatory joint pain. It starts in the morning. With rest, it worsens. If the patient is doing jogging or exercise, then the inflammatory pain vanishes off. So these are the points you have to understand. And usually the inflammatory pain involves more than 3 joints, but it can be seen in less also. So these things is very important. And other joints can be due to degenerative changes and other causes. Now, when you are talking with your rheumatologist friend, what I have realized that people will be telling that it's very important to have a ophthalmology and rheumatology collaboration and all. But it is important how you are communicating with that. My rheumatologist, I try to guide them. I try to dictate them. I tell them, for example, a scleritis patient, I'll always send to my rheumatologist. A patient with HLA-B27, I'll always send the patient to rheumatologist that look, any other joints are involved or not. Any cases of uveitis where I have advised an ANA is coming positive in like 1:40 or 1:82 dilution, that is strongly positive ANA, I will send. Any patients with history of multiple abortion, some non-specific abdominal pain, of a history of photosensitivity, this can be lupus. So I'll send to my rheumatologist. Now, when I send to my rheumatologist, you have to understand that they are very sometimes very aggressive in treating conditions, and you have, sometimes they are very I'll say very callous in treating the conditions, like necrotizing scleritis. If you send to your rheumatologist and you don't mention that eye is about to perforate, you will see that rheumatologist has examined the patient's all joint and all, and started like 7.5 mg methotrexate, which is nothing. So these are happening because ophthalmologists are not telling rheumatologists what to do. The eye is your domain, and you, a patient of HLA-B27 positive with secondary steroid response. So these are the patients, if you send to rheumatologist, he will examine the patient. He will tell, no, everything is fine. I'll give sulfasalazine and I'll send the patient. The problem here is, if the patient is on sulfasalazine, if the patient gets 2-3 attacks of anterior uveitis, again you have to start a topical steroid. And the patient is a known steroid responder. So now a rheumatologist, he won't understand that what is steroid response. So it is your duty to tell that you start him on immunosuppressive methotrexate. I don't want any attack. So until and unless you convey this to your rheumatologist, they will treat accordingly their wish. So necrotizing scleritis or any kind of scleritis, any kind of systemic rheumatic disease which has a secondary, because any inflammation you need to go for oral steroid or topical steroid. So if the patient is a steroid responder, you have to strictly tell your rheumatologist that I can't afford another attack of inflammation because it will cost to the patient. So that's, I think, important.
Thank you. Thank you so much, sir. I think the last response was exactly something that I have faced, where rheumatologist is only starting sulfasalazine. And so in that respect, sir, would you, what are the cases in which you would rather yourself begin with biologicals, etc., or would you always advise the rheumatologist to choose their choice of biologicals? Like you had mentioned that you would.
See, in India, the biological cost has come down significantly after that biosimilar for the adalimumab has launched. So there is no option of going for other biologics like infliximab and all. These are not human biologicals. So if you inject them, they are more prone to allergic reactions. But the adalimumab is cheaper, and there is no other choice right now we have other than adalimumab. So I don't think we have much here. If the patient cannot afford adalimumab or biologic, which cost around 6,000 or 7,000, I ask them to go for the JAK inhibitor. That is the tofacitinib, which is available in oral formulation or oral tablet.
Right. Thank you. Thank you so much, sir.
Thank you. Thank you, Partha sir. So, sir, we have this unique thing in our journal club. We have the certification at the end, and thank you, sir. Thank you for being here, and you have really been a guiding light and inspiration. I mean, I remember you, I think, getting the IJO Medal of Honor at Gurugram, if I'm right. And I mean, it's really an inspiration, sir, the work that you have done. And thank you for taking your time for being here for the YOS. And it's always a honor and privilege to learn from you. Every day we end up learning something more. And I think thank you for enlightening us with all your valuable inputs. So we are very grateful for all your learning. With that, I would like to pass it on to Dr. Niranjan to introduce and certificate the next person.
Thank you, Prasanna sir. So next up we have the presenter of the day, Dr. Fatima Fahima A, who presented wonderfully on the Collegium of Articles. And thank you so much, Dr. Fatima. Next, we have our esteemed panelists. The wonderful thing about them was all of them immediately agreed and consented to be the panelist for this session. So thank you, Dr. Karpagam ma'am, thank you, Dr. Jonathan, and thank you, Dr. Eliza, for accepting the invitation to be a part of this journal club. And we look forward to having you as a panelist in the future sessions too. And next,
thank you to Niranjan. So Niranjan has not only been a pillar in getting our academic partner on board, who's Micro Labs, and he, along with Dr. Ayushi and Anujit, they have done a tremendous work for the Journal Club, and I think the thing really catches you, right? The idea is we wanted to make sure each specialty, what are the topics that we can really target and share knowledges like this between discussions and deliberations, and having a candid discussions on how we can go about things. And Niranjan has been very instrumental even in today's skeleton of Journal Club. He has been the pillar along with Dr. Anujit. Anujit, again, he has been one of the members who has been part of multiple journal clubs since the last edition. And of course, Ayushi as well. And myself being the lead of this, along with Dr. Devakant and Nilesh, who are the leaders and the torchbearers of YOSI. I think with that, handing it back to Niranjan for the and the team for the closing comments. Over to you, Niranjan.
Thank you, sir. Thank you, Prasanna sir, for always being the leading light for us in this venture of Journal Club. And do we have our anybody from Micro Labs to say a few words before we call it a day? Kishore?
Yeah. On behalf of Micro Labs, Microvision, sir, it is really indeed a pleasure to associate with the YOSI Club. Thanks a lot. Thank you, Dr. Niranjan.
Thank you, Kishore. And thank you each and everyone for being a part of today's Journal Club, and all the audience who have been with us throughout the Journal Club, and to make it available to each and every young ophthalmologist across the country. It will be archived in our YouTube channel. And I'm sure no young ophthalmologist or any ophthalmologist will want to miss out on such a wonderful session on uveitis, which is one of the vague topics in ophthalmology. With that, we'll call it a day. Thank you and have
just one more. So as you can see, all the YOs who are seeing it, you can be on the other side. Just put a mail, and we'll be happy to have you as a presenter and have a discussion and deliberation on more such papers. And we would also like to acknowledge again Niranjan and Mr. Prakash, who helped us with the flyer. And also Team Numerotech, Manjula ma'am, if you are here, Sai sir, thank you. I think since you took over in the last 1 year, we have had a seamless support in the seamless streaming. Yeah, I would like to switch on, ma'am. We can go off live, Manjula ma'am and Team Numerotech, and I would like to request Partha sir, Jonathan sir, Eliza ma'am, switch on your cameras. We have this selfie photograph or the grid photograph, which we do it in YOSI, which we would like to have you guys in our newsletter. Anujit, you are taking the pictures?
Yeah. Everyone, if you can just hold the YOSI peace sign. Thank you so much.